welcome everybody. I think we'll get started. I think there are folks still joining. Kathy has put on the recording.
Outbreak, and then it just kind of turned into our whole building. So
there's my card, and I just need to.
Somebody is not on mute.
Okay. All right. Let me just
conversation.
getting on this news hour.
Sarah, I'm gonna mute all. If it mutes you, you'll have to unmute again.
Yeah, from DHS actually, but.
All right, thanks Dave, that helped. All right, we'll go ahead and get started today. Good morning and thank you all very much for joining us today. It's been a long time since we've had a news hour. We were having them pretty regularly a year ago, and then we stopped, I think, in the summertime, and it got really crazy in the fall, which we don't have to tell any of you. Today, I believe, actually is 2 years since we first learned of COVID here in the US, and I think you all know that was in the state of Washington at one of our fellow nursing facilities in Kirkland, Washington, which got this all started. I can't believe it's been 2 years. Really, all I can say is wow. And just really want to take a few minutes to
Sarah, you need to unmute again.
All right. I don't know what you last heard me say. I'll go back to today. It's been 2 years since we first learned of COVID here in the US. I think many of you really know it was the state to the north, Washington State, in a nursing home in Kirkland, Washington. And I know we all watched that play throughout the time up there, and want to take an extra minute just to extend my sincere gratitude and thanks to all of you and all of your staff in the nursing homes for your continued due diligence and dedication to caring for Oregon's most vulnerable citizens who live in our nursing facilities. We have a lot on the agenda today, so we're going to go ahead and get started. And because there's so much on the agenda, we want to make sure we get through all of it. If we can ask you all to hold your questions to the end, and if it would be even better putting those questions in the chat. If we don't get to it, we'll be able to retrieve those and get answers back out to everybody else. So with that, I will get started. COVID data update. I honestly don't even know what to say. The last, 3-4 weeks, it's been nonstop putting on executive orders, which means you have positive cases in your buildings. Right now, today, 122 of our 130 nursing homes have an executive order in place. That's 94% of our buildings. I can only imagine what you're all dealing with actually in the facility versus us sending these out and tracking all your emails coming into our licensing box. It's been overwhelming. The 3-day weekend, we were just, I don't want to say we were shocked to come back to as many as we did, but it was all hands on deck helping our licensing staff to try to stay ahead of that and get back to everybody and get EOs in place as they were coming in. So of those 122 nursing facilities, currently 66 of those have positive staff only, 53 have both staff and residents, and 3 have residents only. So that's another turn that we've seen here with the Omicron variant. Is previously it was mostly staff and you really had very few residents and staff, or residents only. So that we know has taken a toll on staffing and what's going on in your buildings. So with that said, many of you are having the nurse crisis team, licensed nurses and CNAs deployed to your facilities. I'm really pleased that we're being able to assist you guys with that staffing through the state. We've had a few questions from buildings whether you can report those into the PB&J reporting, which is the payroll-based journaling, which feeds the Nursing Home Compare and your 5-star ratings. We reached out to our CMS partners in Seattle, and yes, indeed, you can report that into PB&J, but as long as you need to be sure you have an invoice from the state that lists the employees that we provided to you and the hours that were worked. If you're not being able to report those, your staffing is not going to look good, and that definitely could be affecting your 5-star status. So yes, please be reporting those. If you've got those contracted staff in your building providing care, be sure to put that into PB&J. One other reminder I'm going to give with the many executive orders that are in place, we revised the executive order sometime back that you are not required to seek our approval or permission prior to admitting or readmitting residents. We know that was holding folks up, and we are really trying to be good partners with the hospitals and getting folks out of the hospitals and into the nursing homes when that's possible. So just, we're asking you to send us a daily email attestation that yes, indeed, you have admitted residents and you're able to follow all the infection control protocols that are outlined in the executive order. So with that, I'm going to turn this over to Dave to talk about hospital discharges to nursing facilities.
Yeah, thank you, Sarah. This is Dave Alm. I'm the licensing and corrective action manager within the nursing facility licensing unit. This is really just a little reminder for everyone. As you know, there's a bit of a crisis in the hospitals in many areas right now where they're trying to discharge individuals as quickly as possible to make room for others. And we've heard a couple hospitals send concerns about facilities either requiring residents to be vaccinated or requiring testing to determine whether they're positive or negative prior to admission. And I just want to remind you that you can't require that as a condition of admission. You know, some hospitals will probably do this voluntarily, or they may start the vaccination series. And if you're able to work with your hospital, and again, they're willing to do it, there's no problem with that, but you can't require hospitals to test, and you can't require individuals to be vaccinated prior to admission. So thank you for that. And I think, Sarah, I think you're up next.
Thanks, Dave, and appreciate you introducing yourself. It reminded me I didn't introduce myself. It's just like, seems like you're all old friends and we know each other, but Sarah Odell, Nursing Facility Program Manager. So I'm going to go over a couple of CMS memos that I'm sure you have all seen and read and know them inside and out. And I'm presenting these, and I've got managers, I hope, on the phone, and I did happen to see one of our trainers pop on, so I'm going to do my best to give the highlights out of these two memos. The first one I want to talk about is QSO 22-02 all. It came out November 12th, 2021. It's about survey activities and increased oversight in our nursing homes. First and foremost, the focused infection control surveys that we were doing very routinely, which were referred to as the 3 to 5 day surveys, are no longer mandated through CMS based on what you are reporting to NHSN. Although we are still required on an annual basis to do 20% of our nursing homes to conduct these focused infection control surveys, which would be 26 buildings. They will be a standalone focused infection control survey, or they could be combined with complaints. We'll prioritize those based on any new cases and low vaccination rates. Recertification surveys are underway. We started those in November. What I want to explain to you all, which more falls onto us, you all know prior to COVID, our survey interval was creeping up, mostly related to not being fully staffed with surveyors. So the interval with the surveys that are happening right now, your annual recertification surveys, will restart our survey interval average, meaning a survey that we do today and exit today to determine that interval will be based on the next survey we do within the next 12 to 15 months. It won't be going backwards, where is how those intervals were determined prior, but CMS realized that nationally the survey interval is so out of whack because of the suspension of the surveys and the backlog of complaints that we're all trying to get done. So it's from here moving forward. Otherwise, that survey interval would never probably have come back into compliance, or I think somebody on our team figured it'd be 10 or 15 years. So I think most of you know we are mandated by CMS to maintain a 12.9 month average interval and no surveys over 15.9 months. So we are busy doing that. Some of the research surveys will include complaints, but we're trying to do those on a separate investigations as standalone complaints to try to bring those numbers down. So next I want to talk a little bit about our facility reported incidents and complaint backlog. Our highest priorities continue to be those complaints that we triage at what we call an immediate jeopardy, meaning there's an immediate do a 2-day working day response to those complaints. Those continue to be our highest priority, and we do those as they come up. Our next priority are the non-IJ high complaints that require us to do a 10 working day response. That's where our biggest backlog is at this point. And want to be really clear to everybody that all of those complaints that have been triaged at that level will get an investigation regardless of the age of those complaints. They could be a standalone complaint, or you might see us attaching them to a research survey. And some of those complaints, and we've heard from some of you that surveyors are conducting complaints that have upwards of multiple intakes and multiple allegations. It has taken our staff longer than maybe a research survey to do those. We appreciate your patience in working with us as we work through those. They do become challenging when some of those are probably at least 3 years old. If residents aren't still in the building, or staff that knew those residents are still in the building, has become challenging. So we just request that you work with us and understand the situation, what we've got going on. The next triage level of complaints is called non-immediate jeopardy medium. This includes both complaints and facility reported incidents. These are designated to be investigated at the next scheduled recertification survey if they were received within 1 year of the scheduled survey. We are required to investigate all allegations in this category if they involve staff to resident abuse, neglect, or misappropriation of resident property, regardless of the age of those reported complaints. If they're not investigated at a research survey, again, we could conduct those with a standalone complaint investigation. Any of the complaints and facility reported incidents that are greater than a year, our surveyors will review those for patterns of poor care and investigate on the next recertification survey or a complaint survey. The fourth category is non-immediate jeopardy low. Per CMS, we are not required to investigate these complaints at this point. Currently, we are reviewing our state statute and rules regarding the ability to close these without investigating them. We are consulting with our Department of Justice on those because we have statutes and rules that don't necessarily allow us to do that, and drafting proposals of how we might be able to close some of those. We do have the discretion to include any residents that are named in those allegations who are subject to become part of the survey sample, or if we determine a pattern or similar allegations have been reported to us that fall under those categories. For recertification surveys, CMS is allowing certain mandatory survey protocol tasks to be discretionary or triggered based on identified concerns while surveyors are prepping offsite prep. These could be concerns raised by the long-term care ombudsman or a previous pattern of citation. The tasks that could be discretionary or triggered include resident council meeting, dining observation tasks, and medication storage. I'm going to move on to the next CMS memo, which is QSO 22-07 all. This is about health care staff and vaccination. This memo came out December 28th, 2021. It includes a 90-day timeline for compliance. There's a new tag F888 that has regulatory language and guidance on the vaccination exemptions, and a link to the CDC document which outlines the clinical considerations for and contradictions for vaccine administration. This new regulation requires that the facilities all have policies and procedures developed and implemented outlining that all staff are fully vaccinated against COVID-19. Staff include facility employees, licensed practitioners, students, trainees, volunteers, and individuals under contract who provide care, treatment, or other services for the facility or its residents. Staff does not include those who conduct telehealth or telemed services provided to the facility with no direct contact given to residents. At a minimum, the policies and procedures must address processes to ensure all staff receive at a minimum a single dose or the first dose of a series of COVID-19 vaccine prior to providing care to residents or other services for the facility. There are some exceptions. Ensure all staff are fully vaccinated except those with exemptions. Ensure all staff who are not fully vaccinated have implemented precautions to mitigate the transmission and spread of COVID-19. Ensure all staff have their COVID-19 vaccination status, including boosters. Staff who have vaccination is temporarily delayed are tracked and documented. Ensure you have a process for requesting an exemption, both medical and religious, from vaccination, which includes tracking and documenting that status. Medical exemptions must include a recognized clinical contraindication. You can refer to CDC document for that, which is signed and dated by a licensed practitioner. Information on the specific COVID-19 vaccine, which is clinically contraindicated and why, and a statement from the practitioner recommending the staff member be exempt from the COVID-19 vaccination requirements based on the recognized clinical contraindications. And you must also have a contingency plan for staff who are not fully vaccinated. We won't be judging that or determining how you made those decisions, in particular with religious exemptions. That's up to you. We don't give that a blessing one way or the other. It's your plans and how you develop that to determine those. So we will be surveying for compliance. We will be looking at this on any survey activity we do going forward. The memo came out December 29th. CMS is expecting full compliance within 30 days of that date. Our survey staff will be looking at in a phased-in approach. So within 30 days of the memo coming out, we expect facilities to have the policies and procedures developed and implemented following the guidance, as I had mentioned earlier. Facility is compliant if 100% of staff have received at least one dose of the COVID-19 vaccine or have a pending request / granted a qualifying exemption or identified as having a temporary delay. The facility is non-compliant if less than 100% of staff have received at least one dose of COVID-19 vaccine or have a pending qualifying exemption or have been identified as having a temporary delay. F888 will be cited unless the facility vaccination rate is above 80% and there is a plan to achieve 100% staff vaccination within 60 days. Within 60 days of the memo coming out, so looking at February 28th, again, all policies and procedures need to be developed and implemented. The facility is compliant if 100% of staff have at least one dose or have a pending qualifying exemption or on a temporary delay. The facility is non-compliant, again, if less than 100% of staff have all of this in place. F888 will be cited unless the facility rate is above 90% and there is a plan to achieve 100% within 30 days. So 60 days from that letter coming out to you all. And within 90 days, the facility is non-compliant if the facility fails to maintain compliance at 100%. And at that point, you will be subjected to enforcement from CMS regarding this mandate and being in compliance with it. I'm not going to go into the survey process. That was also attached to the letter that we sent out with the provider alert. So that's what I have to offer. The next slide is a CMS training link that this is open to the public to review. Encourage you to take a look at that training that is provided. I saw it last week. It's about 51 minutes. There's a lot of slides that are available as well. So with that, I'm going to turn this back to Dave to talk about minimum nursing facility staffing ratios.
Thank you. So Kathy, not to throw a curveball at you, but I'm wondering, I actually am thinking I should pull up that provider alert as I'm kind of talking through it. It might be helpful. So if either, if you can, or if not, maybe you can stop sharing and I will. Oh, perfect. Okay, great. Thanks, Kathy. So I just wanted to take a little time to kind of go through this provider alert that was sent on the 18th, and it was effective on the 18th, where we talked about the minimum nursing facility staffing ratios and some sort of criteria that you guys can use to be in compliance with the minimum staffing ratios. And Kathy, if you could zoom in just a tiny little bit, that might be better. If you hit control, there you go, you got it. And then go down to where it talks about the minimum staffing ratios. That's perfect. So before I get into the criteria, I just wanted to kind of mention why this came about. And you guys are, I'm sure, fully aware that there is a statewide staffing crisis right now for both licensed nurses and certified nursing assistants. And also, on top of that, with the Omicron variant, there is a pretty big crisis in the hospitals due to their not being able to have enough space for everyone. So what we're attempting to do here is to kind of get at a couple different things. One is to sort of ease up a little bit on the minimum staffing ratios, but also hopefully provide some support for hospitals as they're trying to discharge and increase census within the nursing facilities. So the criteria for this, if the facility meets any one of these three criteria, this will apply to you, and you don't need to submit a waiver for the minimum staffing ratios. The first one would be if you're in a geographic area that is experiencing ongoing staffing shortages and the facility has been unable to fill positions. I think right now this is pretty much statewide. I'm not aware of any areas that aren't currently affected by the staffing crisis. So a lot of facilities will probably meet that criteria alone. And we did want to make this, as expansive as possible, but also put some parameters around it to keep residents safe. So the next criteria is the facility is experiencing a COVID-19 outbreak. And as you'll notice, these are all ORs, so one of these three. And the third is the facility is attempting to increase census in order to create additional capacity to assist with hospital decompression. And an example of this that has come up is, as you guys know, there are sort of census points where it's most efficient based on the number of residents and the number of staff that you need. And what this will hopefully help do is allow facilities to potentially increase census by, maybe one resident or two residents or three residents without having to hire a full additional CNA, or in some cases, three additional CNAs to meet the minimum staffing ratio, as long as it's not unsafe. So facilities, first and foremost, need to make sure that whatever they're doing for staffing is keeping residents safe and it's not affecting the quality of care for residents. And then, Kath, if you can move down just a little bit for the next section, up a little bit. I think that's good right there. So the next one is the criteria that facilities must need to meet. And as you'll notice, this is all. So facilities need to meet all of the following criteria. Otherwise, an actual waiver request is required. So if the facility doesn't meet one of these, they would be required to submit a waiver in order to be below the minimum staffing ratios. So the first one is facility must have sufficient staff to meet the needs of the residents, and the facility must not endanger the health and safety of residents. I think that's pretty straightforward. Facility must have submitted a request for additional staff through the nurse crisis teams. And if you are not familiar with the nurse crisis teams, we have a provider alert out. Actually, I think there have been two now that talks about the nurse crisis teams and the purpose. At this point, they are essentially state-paid staff that we're deploying to help facilities that are in crisis. And, it could be crisis because of short staffing, or it could be crisis because staff are out due to quarantine for COVID. So they're in that provider alert, the process is in there on how to request the nurse crisis teams. And that is one of the things that we are asking everyone to do if you are experiencing crisis. The goal for the nurse crisis teams is they're trying to staff up to have, roughly 500 or so individuals kind of available to be deployed. And I know right now that isn't the case, but they are working on trying to get up to that point. And not immediate, it is pretty quick. So I think if, any facilities are thinking about dropping or need to drop below the staffing ratios, I think that's a critical thing, is facilities should and need to submit a request for additional support. And it may not be approved right away, or it could be a couple days before, or potentially longer before the staff may be deployed, but at least having submitted the request. Facility must have made a good faith effort to secure staff through all available contracted agencies and through additional corporate support. And that actually will be covered when you submit the NCT request as well, because they will be asking questions about, have you contracted with additional agencies? Have you made contact with all the agencies? And all that will kind of be covered through that part of it. Facilities must be actively recruiting, and I don't know of any facilities that aren't. So I think that one should be pretty straightforward. Facilities must ensure survey history does not include a finding of immediate jeopardy, substandard quality of care, or harm to residents due to not meeting minimum staffing ratios in the last 6 months. The first two, so if you've had an immediate jeopardy or substandard quality of care in the last 6 months, that it doesn't matter what category it's under. That's just an immediate jeopardy or SQC period. Then you would need to submit an actual waiver request to us. Or if you've had a harm citation and staffing was cited at the same time, and that could be state or federal staffing. And again, if that's the case, then you would need to submit a waiver request. Facility is not using more than 50% nursing assistants, and as you'll notice, this has gone up from 25%. So we're essentially allowing facilities to do that without asking for a waiver currently. And again, if you're meeting all of the required criteria. Facility must maintain weekly staffing schedules showing number and category of staff assigned to each shift. And that's essentially following the current process for documenting staffing shortages or staffing. And I think, the biggest thing I will point out here is that quality of care is still the #1 priority. So regardless of whether you're able to follow this and, potentially have a couple additional residents or be, under the current staffing ratio, the #1 thing that you'll need to ensure is that you are providing sufficient staff to meet the needs of the residents. And I think, we've seen a few waivers come in recently with some creative solutions on how to meet either the RN or LPN minimums or the CNA staffing ratios using potentially alternate staff. For example, using resident care managers or RN care managers, or using PCAs or therapists or some combination thereof. So there already have been some creative solutions to try and ensure that resident safety has been met. And then if you'll scroll down a little bit more, Kathy. And so if under the section where it says, if the facility is unable to meet all of the above criteria, an approved waiver to the minimum staffing requirements is required. That's critical. So again, if you're not able to meet all of the above, you need to submit an actual request for a waiver. We have reviewed our waiver process over the last few days, and we are committed to trying to get these reviewed and approved within 3 business days, with the assumption that everything that we need is in the waiver request. So make sure if you don't meet the criteria above and you need to submit a waiver request, that you pay close attention to the questions in the waiver request form and make sure that everything in there is addressed. And there's a link here. The waiver request form is the APD 0467. Those get submitted to our general NIF licensing email box. And I also included a link to the DHS form server. So if you go into the form server and you can search for 0467, it'll come up right away. So that's where to find the form and where to send it. And then we also just added in the end here a section about using non-certified staff. So nursing assistants who have essentially completed the training but not yet certified, PCAs and therapists. And therapist is more of a general term because I think if it's an occupational physical therapist, they're well trained. Or even if it's a OTA, PTA, I think those staff are also very well trained. So it's sort of a broader term when we say therapists. And I think this just reiterates what I said above. 25% of the NAs can count towards the minimum ratios. However, you can go up to 50%. And when I say that, that means on your quarterly reports, we will still continue to count up to 25%. And we will still, and I just want to make sure this is really clear, we have and we will continue to use mitigation when facilities submit the quarterly reports. So make sure when you submit those that you're putting in there all of the criteria to mitigate, and we will continue mitigating. The one other little piece here is that in some cases we may allow facilities to go above 50%. NAs to CNAs, but that will require a waiver. And, I think we will ask probably a lot of questions around that, because when you start getting above 50%, unless the NAs have been in the facility for a pretty significant amount of time, that's a lot of new staff. And, I think having the certified nursing assistants is really important to, quality of care. But we're not opposed to that if a facility can demonstrate that they're not going to endanger the health and safety of residents. And one other thing, I probably should have pointed this out above, but if you can scroll back up, Kathy, to the first part of it again. So where it says minimum staffing ratios, NA, CNA, and nurses, this covers the entire section 100 of 41186. So as you guys will probably know, there are minimum requirements for nurses, CNAs, under that section. So it does encompass the entire section of that. The other thing I'll point out is that we are not waiving federal requirements here, or allowing you to not meet federal requirements. So the one I can specifically think of is, well, two actually. One, you need to meet the needs of the residents, have sufficient staff to meet their needs. The second is around the 8 consecutive hours for the RN coverage. So our state rule requires it during, specific hours, whereas federal, you just have to have an RN 8 consecutive hours during the 24-hour period. So this is sort of a little bit of easing up on the state requirement, but we are not waiving the federal requirement. That would require a waiver request, and that would actually have to go through CMS for approval. So I just wanted to make sure that's clear for everybody. This is specific to the OARs, not for the federal. And I think that's all I had to cover for this. And again, we'll have time at the end for questions. So, if you want to put them in the chat or save them until we're done, and we don't have too much more to cover, I don't think so. That's it. Thank you. I think Jeremiah is up next, if I remember correctly.
Hey everybody, my name is Jeremiah Adams. I'm one of the policy analysts with the Nursing Facility Licensing Unit. I've probably spoken to many of you or corresponded by email over the last couple of years. I just wanted to run through testing. I'll talk about routine testing. Routine testing is based on the level in your county, and the only folks that would be required during routine testing is unvaccinated staff members. And I think right now every county in the state is high. So when you're in a routine testing status, that would be twice a week for unvaccinated staff. And then about outbreak testing, there was the most recent update was a QSO 2038 revised on September 10th. And it talked about potentially allowing 2 different approaches. One was a testing through contact tracing or a broad-based approach. And the DHS issued a provider alert 21-054 on September 24th, requesting that all nursing facilities continue to follow the broad-based outbreak testing approach, which is conduct full facility testing in response to a single case in a resident or staff member. For outbreak testing, they changed it. I think they initially said within 72 hours, and I think that's what the Oregon administrative rules say. CMS changed it to immediately. So obviously, as quickly as you can get outbreak testing started, the better. And after 14 days of no new positive resident or staff cases, we're able to lift an executive order that's in place. And let's see. Oh, and if somebody has tested positive, it's not recommended that they be tested for the next 90 days after that positive test. It's just a reminder. Go ahead.
Would you like me to click on the memos? It's very helpful on the code, so I don't confuse everybody.
That's okay. The QSO memo is quite lengthy, and those are really the points that I wanted to touch on.
Thanks.
Yeah. You want to go to the next slide, Kathy? And then I just wanted to touch on visitation reminders. I know we've had a lot of questions from administrators recently if CMS is going to make any changes, or ourselves or OHA, about visitation in nursing facilities during this current outbreak. I think DHS management has had recent conversations with CMS, and CMS has indicated that they do not plan to make any restrictions on visitation. And so at this time, we're requesting facilities to allow visitation for folks that want to come in to the facility, obviously following all infection prevention guidelines while they're in the facility. And so that would mean not requiring appointments for visitation, not requiring folks to leave after 30 minutes, or setting a specific time frame, allowing the family and the resident to make that determination when to end their visit, and not requiring them to come in and for the visit at a certain designated time. So if if a family member gets off work at 5 o'clock and they want to come in at 7 o'clock after, you've served dinner, and after they are able to make it to your facility, to please continue to allow those visitations, which I know is difficult. And you can absolutely recommend that virtual visitations or something of that sort, and let them know that if you have an outbreak in the facility, that it's not recommended that they come for an in-person visitation, and you can give them that information, but ultimately allow the visitor and the resident to make the decision if they want to have the visit. And I think that's all I was gonna touch on. And when we finish up, if you have questions about either of these two subjects, go ahead and put those in the chat, and we'll get to those at the end. Thank you.
Hi, I'm Kathy Orias. I'm a policy analyst with Sean and Jeremiah. And we just wanted to point out that our SOQ offices have moved to a new office location. It's a physically locked building, so we are encouraging electronic delivery of licensing materials or anything that's appropriate in that regard. And if you do need to make an in-person delivery, please make sure you look at the alternate address. The in-person deliveries will be routed over to the DHS main office and then shuttled over to our new office, and we're at 550 Capitol Street. And if you have anything to mail to us that cannot be electronically delivered, we encourage you to look at this new address and make note of it. It should be on all of our new letterheads. Things do get biased here and there, but we're working on getting everything updated. You all know what a whirlwind it's been these last couple of weeks, if not couple of years. So that was just my little update on our mailing address and location for our new offices. And at this point, I think Sarah or Dave may want to lead some questions. We can coordinate answers.
I'm happy to help coordinate that, Kathy. One thing I think I probably should mention, and we probably should have put a slide in about this. It didn't dawn on me until just now, but there was a provider alert that came out. Let me check the date on that, January 11th. And it's the one that I think it says urgent before the provider alert. And it has resources like the NCT teams and some other stuff. But one thing I wanted to make sure to call out for you guys is there's a link to a survey in there, a mandatory survey. And we want to make sure you're all aware of that and that you're filling that out. it's vitally important to make sure we're getting that data to help us plan. And, you know, it does affect the decisions around how many NCT, oh, thanks, Kathy, how many NCT staff we may need to have, how many vacancies are out there, and that kind of stuff. So please, if you have not filled that out, go out to that provider alert, and I'm happy to put a link in the chat for you guys, and make sure you complete that survey. And I know it says response required by 1:15, but please, if you have not filled it out, please do.
And what I should note is that this, since capacity issues are very fluid for some of our facilities, these surveys will be coming out weekly and in some cases daily to meet capacity needs from the hospital over to specific facilities. Not everybody's going to be asked to respond daily, but we do want to bring it to your attention that you may get multiple requests for this survey. So be sure and look at the dates. This is we understand this is just one more thing to report on, and, you know, apologies in advance. It's important for us to coordinate openings, capacity with staffing targets. So even though our office isn't gathering the details, this does benefit you in the long run. So please, if you get an email from our group, or it might be from another person, if it's about a survey, check it out and please try to be responsive. Hopefully they're quick and easy, and we're just going to be sending out the link from now on. So I just wanted you to know this won't be coming out through Gov Delivery necessarily. That's a really wide net. We're trying to just focus on the facilities that might need staffing resources. So again, just be aware that this will be coming out through March, probably over the next couple of months, to keep on point with where the staffing resources need to be to accommodate bed capacity. That's all I'll say on that, because it's still moving target, but more to come.
Thank you, Kathy.
You're welcome.
So let me make sure we don't have any hands up right now. No. So I'm going to go through a couple of the things that were mentioned in chat really quick, in case you guys didn't see the chat or don't have access to it. There was a question about whether facilities are able to keep nursing assistants over the 4-month max time to get certified, and that the blanket waiver from CMS is still in effect. It has not been discontinued, so yes. One thing we learned recently that I will mention, there is an OSBN rule around maximums. So, and I might get this wrong, but it is, I believe you have 1 year to take the test, and then from whenever you take the test, you have 1 year to be certified. And again, we're not waiving the OSBN rule, so I thought I would just mention that. I haven't heard that facilities are, you know, needing much beyond the 4 months, because I think testing is available, at least again that I've heard. But it may not be necessarily true in every area. But yes, to answer that question, the waiver is still in place from CMS. Regarding outbreak testing, this is talking about, I think it's the the routine testing during an outbreak. So the recommendation for every 3 to 7 days. I have not heard that is the recommendation is changing, although as you guys have probably seen, things change daily on, you know, some of the recommendations and what's happening. If we hear anything, we'll make sure that that gets out to you guys as soon as possible. And Jay, if there's anything you want to add, feel free.
No, I haven't seen any new information that they're going to be changing the outbreak testing. I know, you know, they made the change as far as routine testing to only requiring routine testing for unvaccinated staff, which was a huge change. Prior to that, you know, you were having to test all staff a certain amount of time. So, you know, I know it depends on your vaccination percentage of your staff. Some facilities, you know, could be as low as 50 or 60%, and some as, you know, high as 95, 98%. So I know that helped a little bit in the amount of testing facilities had to do, but now that almost every nursing facility is in outbreak status and having to go through outbreak testing, I know that's hasn't been helpful. And I know I'll talk a little bit. I know we heard from a few counties recently and a few facilities that used to get rapid test kits from the county, and the counties are indicating that they have not received their shipment. I understand there is a backlog and a very low inventory of the rapid test kits. So we're just asking facilities to do everything that you can. If you're not receiving your shipments from the county and they're not indicating when they are going to have test kits for you, if you could, try and obtain those, facilities could try to obtain those yourself, or if you have contracts with labs to do a round of PCR testing, if you're able to do that, just to do the best that you can with the resources that you're able to obtain.
Thanks, Jay. The next question is around, so if someone tests positive, that they're not recommending any test after 90 days, and the question was whether that applies to the POC rapid test or PCR test. And the direction from OHA from pretty much the beginning has been that a positive is a positive. So whether it's a PCR test or a POC test, they consider it, if it is positive, it's positive. And somebody can please correct me if I'm wrong, and I don't know whether you guys are actually able to do this realistically, but the last recommendation I had heard was that if someone's symptomatic, then POC tests are a better indicator than if someone is asymptomatic. Now, again, you may not all have access to PCR testing for individuals without symptoms, but generally speaking, that's what I've heard. And the PCR tests are more accurate if individuals are asymptomatic. So the short story here is from what we've heard again from OHA, you can't test your way out of a positive. So you can't, continue to run tests until somebody is negative. Once they're positive, they're positive. However, if you feel like someone is a false positive, contact local public health and talk through it with them. They may have some recommendations. And we have in a few cases, if their local public health has said, no, we feel like this individual is not positive, we have followed their lead, but it hasn't happened that frequently. Next question is, would you like us to do the survey again? Kathy, I think you said that they're doing sending new surveys weekly, right?
What I would do is, if you have not responded at all, make sure you respond once. They're going to try to whittle that list down to reach out to non-responders. But again, if you get it and you have responded, feel free to disregard or just look at the date and see if it's a new due date, and then try to triage it if you need to respond. And I'm sorry that is confusing, but it's moving very quickly, and it sounds like it will be a direct email. So don't look in Gov Delivery. It sounds like it'll be from like the NF licensing box or maybe an SOQ box, but we'll have survey in the subject title, staffing survey. So that's all I can really share right now. I did want to say one other thing though, Sean, I did not get the slide inserted for the staffing template, but I did distribute it and it's being posted as we speak. So you can speak to that, Sean. Sorry to put you on the spot. We can't hear you. Nope. You're muted. There you are. I wonder if we need to unmute you.
Or you might need to try *6. I'm not sure if that helps. Well, since Sean's not able to talk, I'll just mention really quick that the report Sean did do, there is a new 2022 quarterly staffing report. it's ready to be sent out, and it is being posted probably as we speak, right, Kathy? Okay.
Yep. And then I did see a question about the survey. What did that just pop up about a survey? Oh, what did it say? I don't have access to that right at the moment.
The one that we just covered was, would you like us to do the survey again if they have already done this? I think you got that one covered.
If you responded one time so far, that's all we've asked so far.
We've got about 2 minutes left. So next question is facilities with the bariatric resident requiring to have 1 extra CNA. Honestly, I think that the direction around that alert happened so quickly that I didn't think about this. I don't think any of us necessarily thought about it because it's in a different rule. So I think right now my suggestion would be to submit an actual waiver request for that part of it, and we'll review it that route.
The one question I think I saw was if a waiver request was pending, do they need to resend it? And I think Sean, I know you probably can't respond, but Sean was kind of starting over with all of the waivers. So you would look now at the criteria, see if you still want that waiver, and just send that back to us. And we have some quick turnaround times we're working on the waivers. Okay. So yeah, relook if you need a waiver, resubmit it if one's pending, and just confirm that you still need all that information, and we will be responding ASAP.
Thanks, Kathy. And then there was, I think, a clarification on the 90-day question. So asking for retesting after a positive test. I don't know, Jay, if you want to talk about that part of it.
Yeah, I think what probably talking about is, I know a lot of facilities, it might be their internal policy. I think a lot of facilities are using the POC test or Binex, and then if there's a positive, that you're following up with a PCR after a positive point of care test. And if that's your policy, you can continue with that strategy. I think we were talking about, as far as in public health and OHA's determination, it's near impossible to determine if it's a true false positive or not. So whether the PCR test comes back negative or positive, 99.9% of the time it wouldn't change public health or OHA's determination that it's still a positive result, which would enact the outbreak status.
And Jay, I think just one more clarification that just came in. This is around the return to work with negative POC.
Oh, okay. So I know we've asked facilities to reach out to local public health if you want to either, one, bring back an asymptomatic staff earlier than the 10 days. I think it's 5 days asymptomatic and then a negative test, or if you're in complete crisis staffing mode and you are requesting to use asymptomatic positive staff to care for positive residents. Again, talking that through with local public health and getting kind of their approval to move forward with that. And if they approve, just let DHS know if that's a route that you're having to do to be able to provide appropriate care and services.
Thanks, Jay. We're a little bit over time, but I'm willing to keep going. If any of you guys need to jump off, that's fine. One more question. This might be for you, Sarah. Since Oregon has a vaccine mandate since October, has an analysis been completed regarding the Oregon requirements and CMS requirements?
I'm going to say no, but CMS's requirements are much more comprehensive, and that's what we'll be following. And great if our staff have already gotten there, but CMS has added more with the policies and procedures that need to be in place. And we'll be looking for compliance with those at 30 days from the December 28th release of that memo. Hope that helps, Linda.
Thanks, Sarah.
And there's
another.
go ahead, Dave. Go ahead.
I was going to say there another follow-up question on the 90 days. So if a former positive resident or staff less than 90 days and there's a round of outbreak testing required, no testing within 90 days for outbreak using POC. That's my understanding, that if someone tests positive, you don't need to include them in the testing. Is that, Jay, is that consistent?
That's my understanding as well, Dave.
Hopefully that answered your question. I think we're at the end of our chat questions. I'll give folks an opportunity if you want to raise your hand or just jump in with any questions or put anything else in the chat. I'll just give you a few seconds of silence and then we'll have Sarah wrap up.
I'll just say also, we're trying to answer questions that are coming into the NIF licensing box as quickly as we can. And sometimes we can answer them within minutes, and sometimes it may take several hours. We're trying to get them all answered in the same day that we receive them. If you have something urgent, please give one of us a call, myself, Kathy, or Sean, and we can help you out, hopefully over the phone, and answer your questions more timely that way as well.
Kathy, our phone numbers are out on the website, right? Okay.
Yes, they are.
That would be out on the Nursing Facility Licensing Unit website. If you do a search for NFLU or Nursing Facility Licensing Unit, it should be one of the top results.
Along with the NFL will come up under that, so.
Yeah.
Oh, and just one other quick reminder. If you're sending an email, it would help to send it to the NIF licensing box instead of personally to myself, Kathy, or Sean, in case we're out of the office or potentially for an extended period of time. I know I answer a lot more emails quicker in the NIF licensing box and only go to my personal email box a few times a day just because of the volume right now. So you can include myself, Kathy, and Sean as well, but try and send that to the NIF licensing box primarily.
And Rufus agrees. Thanks, Jay. All right, looks like we don't have any other questions. So Sarah, if you want to do a wrap up.
All right, thank you all very much for attending today. I hope this information was helpful, and if you continue to have questions on anything we reported out on today, please, as Jay said, send that to the NIF licensing box and we'll get our heads together and get answers back to you all. Again, thank you all very much for the work that you're doing out there during this time, and I really hope over the next year, we'll be talking something else besides COVID. Anyway, take care, everybody, and again, thank you so much for attending today.
Quick reminder, the recording, Kathy, will be posted on the website?
By tomorrow, yeah.
Okay, yeah, by tomorrow on the NIF website. I can't remember which section it's under, but it should be posted there.
Our communications page.
Thank you.
Uh-huh.
All right, thanks, everybody.
Thank you.